of this society was with us and participated very actively. Dr. Nafla is a senior consultant in medical biochemistry at the Sultan Qaboos University Hospital, assistant head of the Department of Clinical Biochemistry. She completed her training in clinical biochemistry or medical biochemistry at the University of British Columbia in Canada in 2009 and awarded a fellowship in the Royal College of Surgeons and Physicians of Canada. She has numerous certificates. She has a certificate in laboratory quality management in 2007, certified American Board of Clinical Lipidology from the National Lipid Association. She has a Lean Sigma, Six Sigma green belt, and she is very active in education. She is actually sharing in the committee of residency program in biochemistry at Oman Medical Specialty Board. Without further ado, I would like to welcome Dr. Nafla once again to give her talk. Please, Dr. Nafla.
Thank you, Dr. Zuhair. Nice to see you again.
The same here.
I would like to thank the Saudi Society of Clinical Chemistry for this very kind and honorable presentation and invitation, and Dr. Samia as well. Inshallah, when this pandemic is over, we'll all meet in person, inshallah. Without further ado, I'll just go right into the presentation. So it's the lecture today is about COVID-19 biomarkers. Do they make a difference in the diagnosis, management, and prognosis of patients with COVID-19? So here we're talking about mainly, first we'll go an overview of the scale and pathogenesis. This was done eloquently by the first speaker of this session. I'll not go over it too much. Overview of a biochemical, hematological, immunological markers. Then factors affecting variation in biochemical immunological responses, and overview of a single center study in Oman that was done in Oman retrospectively. Can everyone hear me? Is it clear?
Go ahead.
So the pandemic started in December of 2019 with, as Dr. Nasreen said, for 41 cases, and now we have 61.5 million cases almost 1 year later, with 1.5 almost million deaths. That is a huge number of progression and a large number of cases, so that is what a pandemic is. The COVID-19 is associated with 2% fatality rate. If you compare it to the SARS, it was 10%, and MERS is 34%. Seemingly, they are more fatal. Fortunately, alhamdulillah, it's less than the MERS and the SARS, but the scale is so huge. So it is kind of a blessing that it is really a blessing that it has only has a fatality rate of 2% compared to the SARS and the MERS. So to understand the biochemical response and how it happens, it's important to understand the pathogenesis. So on the cells, alveolar cells and in the epithelial cells, we have two important proteins that are crucial to the pathogenesis of the disease. The first one is angiotensin converting enzyme receptor 2, type 2, and the TMPR SS2 gene protein. So the coronavirus, through its spike protein, binds to the ACE2 receptor, and then from there on, the TMPR SS2 protease, serine protease, actually primes the virus so that it is able to be engulfed by the epithelial cells. Once it is engulfed, there is a replication of the virus, release of the mRNA and RNA, a replication, reassembly of the virus, and then it is finally released into the circulation, where it causes all the havoc that is the result of that causes morbidity and mortality in the patients. So if we are to remember, most important thing in this diagram is the ACE2 and the TMPR SS2 protein. To understand the severity of the COVID infection, It seems now we understand the pathogenesis and how it is emerging. There seems to be 3 different stages of the infection. First, you get a T cell deficiency that is expressed in the form of lymphopenia. And this lymphopenia becomes progressive. After that, the patient goes into systemic hyperinflation with a peculiar time course, often increasing at a late phase, just when coagulopathy is increasing as well and fatal organ damage is happening. And the last and the most fatal stage is the COVID-19 associated coagulopathy, which may extend even after the so-called COVID recovery. And it's a very important realm of interest and research to look at post-COVID and what it does in patients. So the risk factors for development of severe disease and admission to ICU and mortality are as follows. The underlying conditions are like old age, hypertension, comorbidities like cardiovascular disease, chronic obstructive pulmonary disease, diabetes, obesity, malignancy. Obviously, in our region, diabetes is very important. It's very prevalent. And then so we have so many patients coming in with COVID and coexisting diabetes, which increases the virulence of this virus and how it presents itself. Then on presentation, clinically, high fever, dyspnea on admission, and a high clinical score, which is called the QSOFA score, which stands for Quick Sepsis-Related Organ Failure Assessment. When this score is high, then the chances of high morbidity and mortality is very high. Coming straight to the laboratory markers, the reactive raised CRP is quite high. And cutoffs, we are clinical biochemists, so we need to know cutoffs. Cutoffs are very important. A rise in CRP above 15 milligram per liter early on is an indicator that this patient will progress further. And if it is more than 200 milligrams per liter, the odds of death increases by 5 times compared to the counterparts of patients who have less than 200 milligrams per liter. Similarly, a raised ferritin, raised interleukin-6, which is cytokine, raised ACE2 expression, high neutrophil to lymphocyte ratio, so high neutrophil and low lymphocyte counts, raised lactate and lactate dehydrogenase is very high. It's also an ominous sign. A raised D-dimer above a cutoff of 1 microgram per ml is a bad sign. Raised procalcitonin, serum, sodium, urea, creatinine, liver enzymes are all bad signs, and bilirubin as well. One of the things we want to know that there are so many non-fancy or just your general non-specific biochemical markers that are very important in categorizing your patients into mild, moderate, severe, and critically ill. And they can play an important role in helping the doctors direct treatment. And this is one of the cost-effective ways of looking at patients and also directing treatment in a good way. So looking at the biochemical markers, one of the questions that come to mind, what are the cutoffs that are clinically relevant? And the second question is, are there any sex-specific patterns, like male and female? Are there a difference between male and female? Now I look through the data and the literature that's out there, and one of the very good publications that I found was a meta-analysis of that included 52 studies after very vigorous selection, and it looked at the prognostic value of selected laboratory and biochemical markers. Looking at this slide, the 3 markers that seem to be, or the 4 markers that seem to be very important, are the total white cell count, a raised white cell count, a neutrophil count, a low lymphocyte count, and a high platelet count. If you look at the ROC curve analysis, ROC, receive operator curve analysis, and you look at the area under the curve, that is highlighted over there. Out of these 5 markers, or whatever, the prothrombin is well included, neutrophil counts, if you take this cutoff, the specificity goes up to 100%, and isn't that interesting? And this meta-analysis is looking at a total cohort of 6,800 patients, so it is significant. And when they did the trial sequential analysis, meaning you don't need to do any more trials to prove that the neutrophil count is a crucial and an important prognostic marker, and it has proven itself that it can help direct management, of course, in addition to other markers. Now, looking at procalcitonin, D-dimer CRP interleukin-6, we find that procalcitonin has a very high specificity, very good sensitivity and specificity to look at which patients need to be monitored closely. After that, the D-dimer is quite sensitive also in looking at these patients, along with the CRP that we've already mentioned. The interleukin-6 and the prothrombin time, they might have a better role if prothrombin might have a better role in post-COVID patients. Interleukin-6 is not measured in all these studies just because of the cost. Many of these studies are retrospective, and some centers don't have the facility to measure interleukin-6. That is why the data on interleukin-6 is not as extensive as others, but it does have a big role as well. Looking at the gender differences, it's bad news for males. With COVID-19 is bad for everyone, but males, young and old, unfortunately, are at a higher risk for morbidity and mortality with COVID-19 compared to the female counterparts. And in the coming slides, I will explain why. Number one, there are some severity markers that are expressed higher in males and females, both genetic markers and biochemical markers. Let's go to the genetic markers first. The ACE2 receptor expression and the TMPR SS2 expression that are important for pathogenesis are both expressed higher in males than females. The biochemical markers therefore rise higher in the CRP, tumor necrosis factor, alpha, the pro-inflammatory factor are all expressed higher in females and males rather than females. The IgG, now there is also a difference in normal and adaptive human immune response. What do I mean normal? Like there's the normal without infection and the adaptive immune response that happens once a patient is infected with COVID-19. If we look at the females, they have a better immune response, like protective. They express more IgG levels in females more than males. There is higher CD4, CD8 ratios, helper T cells, cytotoxic T cells, and B cells in healthy females than males. And that is also in favor of the females rather than the males as a protective measure against COVID. The overall leukocyte counts are higher in healthy males than females. This might help, but as we see, it doesn't. The other factors are not in favor of the males. Testosterone is generally immunosuppressive, whereas estrogen has the mixed effect, immune-enhancing and immunosuppressive effect. Now coming to another biomarker, procalcitonin. As we know, procalcitonin is the precursor of calcitonin and opposes the parathyroid hormone activity, so basically it lowers calcium. It rises, it's usually released from the para-T cells of the thyroid gland. But when there is a bacterial infection, procalcitonin can be released from extrathyroid cells. And when it rises above a cutoff of 0.5 nanogram per liter, it usually indicates a bacterial infection. Interestingly, in COVID-19, the procalcitonin rises to above 0.5 nanogram per liter in severe illness. We assume that it's due to secondary bacterial infection, but we haven't proven this yet. It might be that the viral sepsis itself is causing it, or a secondary bacterial infection. Who knows? We need to see evidence for that. One meta-analysis showed that risk of severe infection is 5 times higher in patients with high procalcitonin than with normal levels. This gives a very high positive predictive value for the procalcitonin. Now, one interesting thing that really, it needs our attention as biochemists and as physicians as general. What is ferritin doing here? Is it a victim, innocent victim? So is ferritin rising just because of the infection, or is it really a perpetrator of cell damage? And so let's just quickly go what ferritin is doing. So severe COVID-19 infection involves a cytokine storm and hyperinflammatory state. Ferritin is the major site of iron storage, storing up to 4,500 molecules of iron in the ferric state. When you have an increased cytokines, as in COVID infection interleukin, there is hepcidin, which is the main iron regulator. Hepcidin increases, and hepcidin increases ferritin with it. And so let's look at this diagram here. And if hepcidin increases, so you have the cytostorm, if hepcidin increases, the ferritin will go up, because hepcidin inhibits the release of iron from macrophages and from cells, especially cells within the liver and the gallbladder, and this as well as in the gut and so wherever the macrophages are, in the gut and the lungs. So here, when the iron increases, what is iron doing intracellularly? As we know, iron, if it is in high amounts, you have an iron overload. Iron is toxic. Iron will react with oxygen and cause the increase of reactive oxygen species and reactive nitrogen species and reactive sulfur species, right? This is because of the COVID infection, of course. And when that happens, something called ferroptosis, or iron causing programmed cell death or cell death. And when that happens, mitochondrial dysfunction happens as well as microbiota, which means the new normal microbes that are seen in the lungs and the liver are also disrupted in the lungs and the gut, leading to hypercoagulopathy and organ damage. Another important point is acute kidney injury and COVID-19. This is something that is overlooked many times, but these patients need to be seen very quickly. Patients who are at high risk for acute kidney injury COVID-19 are those presenting with high serum ferritin very early on. They are high risk for developing AKI. Male patients, hypertensive patients, patients on ACE inhibitors, there's conflicting evidence. Sometimes it may be protective, sometimes and it's something to do with the hypotension, if you have associated hypertension with sepsis. So whoever wants to know more about it, they can read about it. About biomarkers in AKI, it's proteinuria, hematuria, evidence of proximal tubular injury, including hypokalemia and acidosis, a low EGFR and high urea and creatinine. This is caused by the expression of ACE2 receptors on the proximal tubules and the kidney in general, and of course the engulfment of the virus, and the virus causes toxicity to the kidney. Now coming to the quick overview of the study that was done in Royal Hospital Oman, I thank Dr. Manal, who is the PI of the study, for allowing me to present this data, and our resident, Dr. Zakaria Al-Amri, who did this work and did a very good job of doing this extensive work in a short period of time. Anyway, without further ado, 120 patients recruited from February 2020 to July 31st. These were the inclusion criteria: adults with confirmed diagnosis of COVID and patients with baseline clinical laboratory data. The exclusion criteria was patients, anybody with immune deficiency was excluded from the study. Quickly jump to the demographics. We have 62% males and 38% females, and this is just a reflection of how severe the severe cases are. Usually males more than females, and they eventually get admitted, and that's why they were included. Clinical characteristic of patients. So most significant, you can see that diabetes and hypertension was the most comorbid conditions that were seen. And here in the ICU admissions, they were those patients who are ICU admitted, they had associated with increased death, sepsis, and intubation and ARDS. And here the patients, the comorbidities that are associated with ICU admissions, the most significant one was the diabetes, respiratory disease, and liver diseases. Strangely enough, chronic kidney disease was not a major risk factor. Looking at this factors associated with ICU admission, we see that age and hospitalization period played a major role. Among the biochemical markers that were important, all that were important in differentiating ICU from non-ICU, total white cell count, lymphocyte count, CRP, corrected calcium, especially lower collected calcium, ferritin. They were associated with higher ICU admission. Vitamin D, even though there was a big, a lot of attention given to vitamin D in the beginning of the pandemic, even though it's lower in ICU patients, doesn't seem to be that significant in differentiating the two groups. Unless we have bigger numbers, I cannot say. Moving on, interleukin-6 were higher, D-dimer, this high enzymes, troponins, cardiac markers were higher in the ICU versus the non-ICU group. So basically, patients with pre-existing type 2 diabetes, liver disease, respiratory disease are more likely to be admitted to ICU compared to those with comorbidities. Among ICU versus non-ICU patients, there were significant differences in on-admission laboratory and blood serum parameters. So those in ICU had higher white cell count, CRP, ferritin, interleukin-6, D-dimer, ALT, LDH, and troponins, while they had lower lymphocyte count, corrected calcium, and albumin, all indicating basically a status of more coagulopathy, sepsis, and cytokine sort of storm. These are the acknowledgements for the study in Royal Hospital. And at our hospital, Sultan Qaboos University Hospital, we are doing a dual study, Armed Forces Hospital and SQH together. It's a prospective trial, that's why I don't have any data yet ready for you. But basically it's going at the correlation between the level of cytokines, CRP, LDH, and ferritin and COVID-19 infection, looking at the severity and outcomes. It's a cohort prospective study. Patients recruited so far 113. They are distinguished into mild, moderate, severe, and critical using the WHO criteria. So mild, moderate, severe. The mild and moderate cases, we looked at biomarkers. Tested at baseline and day 14. Yes?
Can you conclude in baseline and day 14? Dr. Manal, can we conclude in?
Yes, this is the last slide. Okay. So that is basically it for us. And once we have results, inshallah, we're hoping to publish them. Thank you. Thank you for listening.
Thank you very much, Dr. Manal, for this elegant presentation and sharing actually your exclusive data with us. So I would like to ask all the presenters to open their cameras so we can take a Q&A. Dr. Nisreen, Dr. Hussam. Again, thank you for all the speakers actually for a very thorough and very excellent presentation. I think we have a very strong now background, updated background about COVID-19. And I'll go quickly to the questions because we have a few of them. So I will post the question, and please, if you can have a short answer. If a patient sample is positive after 10 days of infection without any clinical symptoms, can still the patient spread the disease and infect others? Maybe this is Dr. Nasreen, can you answer that question?
Yeah, myself and Dr. Hussam, we can answer this. As Dr. Hussam mentioned in his presentation, we depends mainly on the, to tell whether the virus is viable or not, the only way is to do the viral culture. But when we correlate the viral culture to the CT value, based on the studies mentioned in his presentation, usually most of the patients by day 8, they have non-viable virus. That means, this is why, recently, over the last 3 months, they based the strategy for isolation on symptoms based, not PCR based. So for moderately severe patient, by day 10, from the onset of symptoms, they're usually non-infectious to other, especially if they have disappearance of the fever within 24 hours. And for the critically ill patient, this extended to 20 days. By day 20, for example, if the patient is in ICU intubated, then we consider him non-infectious by day 20, after day 20.
Of course, what Dr. Nisreen has mentioned is a very clear. What Dr. Nisreen has mentioned is a very.
Your mic. Dr. Hussam, can you
description of. Can I, Afwan?
Yes, go
We do
ahead.
not hear you.
تفضل.
Oh, Asif. I think Dr. Nisreen has mentioned, has described that very nicely and clearly. And obviously, this is a very safe strategy. You can reduce the days. The cutoff is 8, but the window just to be extra safe, of course. And I just want to recap on what Dr. Nisreen just mentioned. The only way to know exactly if the virus is viable is by virus culture. And the only way, what we are doing now is speculation based on.
Okay, another question, Dr. Hussam. A group of Dutch scientists reclassified COVID-19 virus as a seasonal virus with high rate of infection. Do you agree with this reclassification?
Well, we had a time when we had H1N1. Seasonal virus, I wouldn't call it a seasonal virus yet, and probably until we overcome this pandemic. Trying to reclassify this virus as a seasonal virus, I think, will somehow have a side effect that is quite negative, and that is we'll try to tell people in a different way or another this is normal, and it's part of the other respiratory virus, which means probably we need that might lead them to soften the precautions they are taking, which is quite dangerous.
Do you want to add something, Dr. Nasreen?
Sorry?
You want to
no.
add? Okay. Dr. Hussam, another question. Is the closed system RT PCR yield the same sensitivity and specificity and reliability as conventional open system RT PCR?
Oh, excellent question. Excellent question. There are several studies that compared the performance of different RT-PCR systems. So the closed system, for example, we have something like the QIAstat by QIAGEN, or something like GenExpert by CIFID. These are closed systems, which are very, very sensitive in comparison to in-house assays or open systems. So in-house assays, of course, something you design in your lab and you validate internally, and you can use reliably. And that's exactly how all assays started in the beginning of the pandemic. And other systems like something like Altona-Test, for example, or Roche-Test are open system, and again they are equal sensitive and specific. But of course, there's a minor margin of error that associate with open systems. The closed system, however, they are more controlled, and there is a less probability.
Excellent. Dr. Nafla, given that you have spoken about all of the biochemical markers, why is the rate of death in COVID-19 in our region is less than the international numbers? Is it something to do with our genetic background, our biochemical behavior? Can you elaborate? You need to unmute, Dr. Nafla. Can you unmute?
Hear me now? Yeah,
Yeah.
so I
Yes.
said it's all of the above. You basically listed the causes. Because we have different, like in Oman, we have 6 different strains that have been identified, and they range from the least pathogenic to the most pathogenic, right? And then our genetics, now we know it's something called epigenetics, right? Epigenetics is not only by the virus. Now we know that even your emotions triggers a biochemical reaction, triggers hormonal reactions, and can actually activate or deactivate. I don't want to talk a lot in the presence of gurus of genetics and viruses, but this is what's happening now with epigenetics, and we see that people vary a lot in their response. So we're just learning, beginning just to look at the tip of the iceberg. And then in the coming future, I think we'll be looking at post-COVID deaths as well. like the sudden cardiac death that's happening, right? What is it? Is it a coagulopathy? And then you say, put the patients on dual antiplatelet treatment. But then you have other patients who are at risk of bleeding. So we really still have to understand what is this virus doing. One of the interesting things is hepcidin, the regulator hormone, is actually encoded by a gene called HFE, which is affected by a protein called TMPR SS6 gene, SS6, which has close homology with the TMPR SS2. So what if the virus is actually also interacting with TMPR SS6 and causing more pathology? So that is a realm for future research, actually. Sorry? I cannot hear you, Dr. Zuhair. Yeah?
A follow-up question. Yes. Do you hear me now? A follow-up question for you, Dr. Nafla. Is there any mechanism explaining how virus increase the cardiac markers? Is it involving anything with the receptors in the lung, in the heart?
There is the expression of H2 on the heart cells, and it engulfs the virus and causes myocarditis. But even the sepsis itself will increase, as we know. Even patients with normal sepsis, you get cardiac injury, and troponins is a non-specific marker of any cardiac injury, not only acute coronary syndrome. So there is myocarditis, there is acute coronary syndrome. There is also the lung injury itself will cause the back pressure to the heart, and also again cause the phenomenon of release of troponins. And acute respiratory distress syndrome again can cause a high troponin. So these patients have to be looked at closely. You need an ECG. You need to follow up the troponins and the clinical.
One more maybe question due to the time constraint. Dr. Nasreen, someone is asking, are we facing another wave of COVID-19? You have to unmute.
Okay. Can you hear me now?
Yes.
Can you hear me? Yeah. If the question is about Saudi Arabia,
yes.
Inshallah, we're not facing a second wave. At least for the last, as I told you in the presentation, for the last 2.5 months, the cases are dramatically low compared to the June, July, and almost for the last 4 weeks we're in a plateau. I can see that even from my practice in the hospital. So let's pray that we'll not have another wave, inshallah.
So on behalf of the Saudi Society of Clinical Chemistry, I would like to thank our distinguished speakers for their excellent presentation and addressing the Q&A. Thank you very much for joining us for this very successful, actually, launch of the first virtual conference of the Saudi Society of Clinical Chemistry. I would like to remind you that tomorrow is going to be the second day, and we're going to start at 3:30 with the workshops, and then we will have our session number 4 at around 5 p.m. So we look forward to join you again, and please be there. There will be very exciting talks, and we hope that you all stay safe. And thank you for joining us this evening. Thank you and good night.
Thank you, Dr. Zuhair. Thank you, everybody. Thank you for your
Thank you, Dr.